Hi, everybody. Good evening, good morning, good afternoon, wherever you are. A very warm welcome to all of you to this IACH webinar, the International Academy for Clinical Hematology. And the topic today is cell modes in multiple myeloma. As we all know, over the past 2 or 3 decades, the immunomodulatory drugs, or IMiDs, have revolutionized the management of myeloma, reshaping both frontline but also the relapse setting and dramatically improving survival outcomes. And yet, as we continue to advance toward more personalized and immune-based treatment, a new generation of agent has emerged, namely the cell modes, cereblon E3 ligase modulators, representing the natural and powerful evolution of this transformative class. Cell modes combine enhanced potency, a broader target engagement, and improved pharmacologic properties, offering new hope for patients who have become resistant to the classical IMiDs like lenalidomide or pomalidomide. But I believe beyond their intrinsic anti-myeloma activity, these agents also possess remarkable immune stimulatory potential, making them particularly well suited for combination with next-generation immune therapies, including bispecific antibodies and CAR T-cell therapies. I know that the current landscape is dominated by excitement around cellular and bispecific immune therapies. But it is essential to remember that the orally administered, easy-to-use agents like cell modes remain a cornerstone for sustainable disease control, both as single agent and in synergy with immune-based strategies. So today's webinar will explore the scientific rationale, some key clinical data, but also future perspective on of this important class. And we are very honored to have today with us Dr. Rahul Banerjee, who is an assistant professor at the Fred Hutch in Seattle. In Seattle, it is 33 minutes past 9 a.m. I guess he is already enjoying his coffee. But Dr. Banerjee has kindly accepted to summarize and to discuss how cell modes can bridge innovation with practicality, extending the benefit of current treatments to broader patient populations while maintaining the convenience of oral administration. Let us welcome Dr. Banerjee and Rahul. The floor is yours, and of course, we'll have our live Q&A at the end.
Wonderful. Thank you, Dr. Moti. Thank you, Mohammed, for this very kind invitation to be here. Thank you all for tuning in. So we'll be speaking about cell mods, as Dr. Moti alluded to, these cerebron E3 ligase modulators, a focus on the International Myeloma Society 2025 meeting that happened last month in Toronto, but also, let me go forward a slide. Here are my disclosures. And so I'd like to spend the time talking a little bit about CELMoDs versus IMiDs, right? The immunomodulatory IMiD drugs, or the IMiD drugs, we call them lenalidomide, pomalidomide, thalidomide. They are the elephant in the room that we all think about. And so I'll spend about 5 minutes talking about just CELMoDs versus IMiDs mechanistically. Then just to set the stage, because many of you are haven't participated and used these drugs personally. Even I myself have only used them a handful of times on trials for my patients. Some of the published data or most extensive data for them. Then we'll talk about what's new and exciting from the last IMS 2025 meeting that happened last month. And then finally at the end, just because Mohammed very kindly humored me to add some editorialization here, my perspectives, right, on the two classes, and most importantly, right, are cell mods truly a new class of drugs, or are they just a newer generation of IMiDs, the way that carfilzomib is newer than bortezomib, et cetera? So we'll talk about all of that. Let's dive in. So first, cell mods versus IMiDs from a mechanistic perspective. So you can see here, this is a fairly nice diagram. Looking at these are molecules. They are indeed molecules that come in different shapes and sizes. A lot of similarities between imids and CELMoDs, right? So lenalidomide and pomalidomide on the top right here, belinamide on the top left, and here the most studied CELMoDs in myeloma. There are others that are being studied in lymphoma, etc. But in myeloma, typically iberdomide, which used to be called CC220, and mezigdomide, CC92480, which I'll often refer to as Iber and Mezi respectively. The business then looks pretty similar. This glutaramide domain on the right here is what binds, I'll show you on the next slide, to a particular component of this cerebron ligase complex. And that's what allows for proteins to be ubiquinated and destroyed. And we'll talk about that. So the business then looks quite similar, but you can see here that in all the ways that thalidomide, lenalidomide, pomalidomide are extremely similar, really only one single amide or oxygen domain different between them. Iberdomide and mezigdomide are much longer. They're much skinnier and longer on the other side, but the binding domain appears to be similarly superficially. In terms of what they do, and I gave Mohammed this disclaimer before the talk, I am not a translational scientist. I have plenty of excellent colleagues who are, so I'm making this talk very clinical. I suspect that many of you in the audience are also very clinical, and so we won't go into the details because everything is much more complex than this. But in brief, on the left here, in the middle, I said, in the middle panel, you can see what things normally look like. There is what's called a tritryptophan pocket inside the cerebron ligase. That's part of the giant complex here. And what it does is it leads to ubiquination, right? Ubiquination is what is used to then tag things for proteasomic degradation. Normally, there are these other proteins. I actually don't even know what they're for, but they're not for myeloma, that normally are the targets, the substrates that get hit by this, ubiquinated, and destroyed. However, when an IMiD or CELMoD binds that pocket, the whole ligase can change, and we'll talk about that shortly. But when it changes, substrates can join. So things that normally don't bind this, but now do bind, and therefore get destroyed. Aiolos and Icaros are these two transcriptional factors that are important to myeloma that then get, bound in here, ubiquinated, destroyed. And by doing so, you then downregulate some of these important genes that are important to myeloma cell proliferation, most notably IRF4, interferon regulatory factor 4, and c-Myc, many of you are familiar with. So again, the idea, what these CELMoDs are doing and their IMiDs are doing at their core anti-myeloma properties, again, as Mohammed mentioned, there are other features as well that I'll get to next. But from a myeloma perspective, what they are doing is they are leading to the degradation of Aiolos and Icaros. That is their core function within the myeloma cell. And by disrupting that machinery, the myeloma cell is no longer able to grow. In terms of what's different between them, and these were slides that my colleague Kartik Ramasamy presented last month at the IMS 2025 meeting in Toronto, you can see that there are fairly profound differences between them in terms of how they behave, what they do to the actual cerebron ligase. The biggest difference is that these CELMoDs, the newer ones that I'll talk about, tend to put this into a closed formation. Again, I won't go into the details of it, but this closed cerebron ligase is the one that actually binds Icaros and Aiolos with much more durability and is able to ubiquinate it much more firmly. And you can see comparing pomalidomide and lenalidomide and iberdomide and mezigdomide, again, these green ones at the bottom are the CELMoDs. You can see here that iberdomide, in general, about 50% of the CELMoD of the cerebral ligase ends up being closed. That's what's needed to actually get Icaros and Aiolos to be knocked down. And for mezigdomide, it's even more potent. And on the right here, again, these are preclinical data looking at this Aiolos degradation efficiency. So how quickly do you knock out that transcription factor that these myeloma cells need? Lenalidomide and pomalidomide look very similar here. Iberdomide appears to be in a class of its own, and mezigdomide appears to be in a class way of its own, where even at very small doses, you are very potently converting that cerebral ligase into a conformation that makes it very easy to knock out those particular transcription factors. So that's the myeloma cells. IMiDs and CELMoDs probably do affect T cells as well. So IMiDs, this is the best diagram I can find, which is fairly vague, and I will admit to that. It's a great diagram, right? It's showing that lenalidomide, just as an example, it binds to the myeloma cells. It binds to these Icaros binding factors. These are actually Aiolos and Icaros, and then it leads to degradation of c-Myc and IRF4, and the myeloma cell cannot grow. Independently of this, we know that at least in some preclinical data, not great preclinical data, but it's out there, that lenalidomide also acts directly on T cells, Same pathophysiology or same mechanism here, but instead you see more IL-2, more Notch, and this T cell becomes more activated, less exhausted. This tends to be hand wavy. Every abstract or paper that almost all of you have ever seen, right, looking at combining IMiDs with other agents, like after CAR T or with the bispecific antibody with this T cell angle, is really hand wavy that, oh, maybe lenalidomide can help potentiate T cells. I will say that it's not that unreasonable to believe that this is true from a clinical perspective, again, to this clinical audience. The examples I would give here is, for example, many of you are familiar with this, and you may have had patients who have had an allogeneic transplant and you're considering maintenance for them for myeloma. We don't typically do allos that often, but we do. IMiDs often people get a little nervous about, particularly if someone has active GVHD. Similarly, if someone got renal transplanted due to amyloidosis and you're debating what to do with them, we typically avoid IMiDs for them as well. And similarly, there were studies of IMiDs in I'm sorry, of checkpoint inhibitors in myeloma that were generally unfavorable. And reality, probably the reason was the main studies of these were done with nivolumab and pembrolizumab in combination with IMiDs. And so you're kind of potentiating the toxicities of both drugs because checkpoint inhibitors prevent T cells from shutting off, keep them on, IMiDs make them work stronger, and you can see toxicities build. Cell mods, on the other hand, I will say, as opposed to the hand wavy stuff I just described, are much clearer in terms of their ability to bind and activate T cells. So there's a couple of examples here. Again, preclinical data that my colleague Kartik Ramaswamy presented here. But you're seeing here, just in brief, that these cells, in combination with T cell engagers with a bispecific antibody, you can see that, for example, pomalidomide helps a little bit, and Mezi and Iber, for example, really help the T cell engager to work stronger and better and more durably, right? The key point is here, if you look at the time axis, the x-axis, durability is what matters here, that these prevent the T cells from being exhausted. Why? You can see in the middle column here, the T cells are secreting much more IL-2. IL-2 is what's needed for the T cells to stay active. And on the right here, just as examples, you can see that if you just do mezigdomide by itself, a T cell engager by itself, or TCE plus mezigdomide in the bottom panel, you can see many more T cells infiltrating into the tumor because they are active, they are not exhausted, they're ready to do their job. Again, this is independent of their myeloma activity. This is a T cell feature. So, concluding things from a mechanistic standpoint, for someone like myself who is not a translational researcher, but I'm lucky to have colleagues who are, so again, we'll come back to this topic. Are cell mods truly a new class of drugs versus are they just next generation IMiDs that are newer and are more skinnier and elongated? We'll talk about that. But from this perspective, I think it is clear that their impact on cerebron is very, very different, as you can see, in terms of how much of the ligase is in the closed pattern, able to degrade IOS and Icaros. And then the T cell exhaustion data already. Cell mods are much newer than IMiDs, but I would argue that the state of the data showing that cell mods make T cells work better is already much stronger than all of the IMiD T cell piece because it's real and it's very easy to show. And obviously, clinically, they behave quite differently as well. So, moving into, we're right on time here, or a little bit behind, we'll stay back on time, moving into the clinical domain. Mm, I'll now speak about two of the published studies about this before I go into the IMS updates, just to give you a taste of what these drugs are like in the clinical trial setting when combined with dexamethasone. So I'll talk about two trials, one for iberdomide or Iber, one for mezigdomide or Mezi. This was the study of Iberdex, single arm study, as I'll talk about, presented or published, I'm sorry, by Sagar Lonial and colleagues in Lymph Hematology a couple years ago. This was a phase 1/2 study. So as you can imagine, in these studies, there are dose escalations. So iberdomide goes from zero point 0.3 to 1.6 milligrams daily. I didn't talk about this in the previous section. These drugs are more potent than pomalidomide, and certainly compared to lenalidomide or thalidomide. Doesn't really matter because you find a dose that works. But just as an example here, lenalidomide, you often need to hit 5, 10, 15, up to 25 milligrams of hidden effect. Here, even at these low doses, you're able to see some type of anti-myeloma effect. And in this particular study with iberdomide dexamethasone doublet therapy, 1.6 milligrams is what they went with. I'm going to pool two cohorts here. So it was about 197 patients, including dose escalation and dose expansion. Again, the pooled statistics here is the median age was approximately 65. About 16% of patients were older, right, over 75. And you might wonder about the tolerability of these agents then. About a quarter of them were high risk, and about a quarter of them had extramedullary plasmacytomas at study entry. This is what we all talk about and think about, right? So this is a heavily pretreated cohort. We use that a lot, but these patients are truly heavily pretreated, right? So 5 to 6 prior lines of treatment. I'm sorry, on average, you could see the vast majority of them are lenalidomide refractory and pomalidomide refractory and PI refractory and CD38 mab refractory, including daratumumab and isatuximab. So about 80% of them end up being triple class refractory, right? And I think triple class refractory is certainly a poor prognostic sign in its own front, very specifically to this idea that, are cell mods different from IMiDs versus not? The fact that, many of them are refractory to both lenalidomide and or pomalidomide is pretty telling. Going into the efficacy first, so you can see here, this is a doublet, right? So I'll show you studies with triplets in the next section in case you're wondering, disappointed by these response rates. You did see responses, right? So about 32% here, you can see in the dose escalation cohort, in the expansion cohort, 26%. And then if you look at the triple class refractory, 30%, right? So patients with triple class refractory multiple myeloma, IMiD refractoriness, proteasome inhibitor refractoriness, and a CD30 monoclonal refractoriness, they are the real unmet need of our patient population. And almost a third of them did see a response here. You can see on the right that these responses weren't necessarily durable, but they were there. Median PFS here you can see was around 3 months or so. But the duration of response among some patients was actually quite longer than that. From a correlative standpoint, again, I'm moving quickly through these slides. I want to focus on the IMS 2025 updates. Here you can see basically when they looked at the dose expansion cohort, you can see Iolos and Icaros tended to go down across the board. These data were from the dose expansion cohort, but you also had some dose escalation people here as well. And you can see people got all sorts of different doses. In general, at the higher doses, you saw that Iolos, again, which is a critical transcription factor for these patients, or these myeloma cells, I should say, went down by over 90% consistently. In terms of safety data, obviously cross-trial comparisons are a sin, and I am guilty of that sin again, as always in almost all of my talks. But it's just worth putting this into context, and so I just happened to choose another study of an IMiD plus dexamethasone, so RD. I chose Pollux as my comparison. Worth noting that Pollux is way different from this study. Pollux only had one prior line of treatment. Again, Pollux was a study of Dara RD with daratumumab versus RD in relapsed myeloma. Only 55% are IMiD exposed, only one prior line versus in this study, right, 5 to 6 prior lines. The vast majority of patients are IMiD refractory. You can see here, just comparing them, hard to compare. These are small n, relatively big n, I should say, but obviously hard to compare these percentages here. But you can see certainly things don't look worse. If anything, I would argue that the muscle spasms, at least here, do appear to be a little bit lower. Perhaps diarrhea is a little bit lower, right? That's a known side effect of IMiDs in terms of their bile acid properties. And fatigue certainly is not worse, right? You might have guessed if you hadn't shown me this first, I would have said, oh, any study of 5 to 6 prior lines of treatment, these patients are going to be more fatigued, more beaten up, more side effects. Certainly does not appear to be the case here. So, in terms of what's next, right? So that was single arm study. Iberdex certainly seems to be quite appealing. And so Excalibur RRMM is an ongoing study right now, a phase 3 study of IBER-DD, so iberdomide daratumumab dexamethasone versus DARA-VD, daratumumab bortezomib dexamethasone, with an opportunity for dosing course correction. I'm just showing the schema here. So what they're doing is they're randomizing patients. Actually, I really like this actually, right? This is a phase 3 study. Normally, as many of you are well aware in myeloma, we have a bad problem of taking the RP2D, the recommended phase 2 drug, from the first study and using it until the end of time. Right, lenalidomide 25 milligrams has not been touched, even as you've gone from lenalidomide doublets to triplets to quadruplets, etc., with very few exceptions. Here, even in this phase 3 study, because you're adding the daratumumab, we knew that 1.6 milligrams was a preferred dose with Iberdex, but who knows when it comes to Iberdaradex? And so they're looking at all of these. People are randomized. There's a control arm there. An independent committee will choose the recommended dose for this regimen based on a number of factors, and then go on to compare it head to head against Theravidi with a much larger N. Again, 1.0 milligrams actually, stage 1 has been completed according to a press release. And so 1.0 milligrams here will be the RP3D, if you might say so, as opposed to 1.6 milligrams, which was what studied before. In case you wonder, why am I putting a press release in my talk? What press release? press release. It's really cool to see science moving so quickly that we don't even have the science yet. I would like to see the data, obviously. I'm sure it'll be presented in an upcoming meeting, but less than a month ago, the sponsor, the manufacturer of the company, actually said that iber so again, daratumumab with iberdomide as a partner drug, not bortezomib, met its co-primary endpoint of MRD negativity with this novel cell mod as opposed to Dara-VD, which is an established, based on the Castor study, regimen for relapsed myeloma. So that's IBRD. Now let's move to Mezidex. So mezigdomide plus dexamethasone. This again used to be called CC92480. This was published in the New England Journal of Medicine by Paul Richardson and colleagues a couple years ago, again with Mezi. So here, relatively similar idea, phase 1 to 2 study. Here, interestingly, they also did various on-off sequences. So should we do 7 days off, 7 days on, 7 days off, 7 days on? Should we do 21 versus 7, the way that we do with typically with IMiDs, etc. So many things were studied here. About 178 patients altogether, including the dose expansion cohort, median age similar. And here, I would say even compared to the prior study, even higher percentages, almost a third of patients are high risk and or extramedullary plasmacytomas. You can see here similarly, 98% are Len refractory, 91% Palm refractory, 81% were triple class refractory, a quarter were BCMA exposed. Probably most of them had gotten a TCR engager or CAR T, probably were refractory or had a relapse thereafter. But these are the patients whom we struggle with in clinic even today. But the paper was published 2 years ago, even today in my clinic, someone like this, I would have a lot of difficulty with finding the best option for them, 6 prior lines of treatment, etc. You can see here that basically, again, several dosing studies were studied here, so small n, but overall, the response rates in the top column here are in the 40 to 50% column, especially with these newer, more modern dosing cohorts, which is kind of really nice to see. Median PFS was 4.4 months, which again might not sound that impressive, but for some of these patients, they did achieve a very good duration of response. I'll draw your attention to the top right of this figure here. Among patients who had received a prior BCMA-directed therapy, their outcomes historically have been abysmal. And the fact that 50% of them received or achieved a response with all oral dexamethasone is wonderful, right? I'm sorry, all oral doublet, I should say, right? A doublet treatment is wonderful. Mohammed spoke to this. I should have said this. I'm sorry. Both mezigdomide and iberdomide are oral drugs. And so the fact that half of them achieved a response with an oral doublet is frankly mind-boggling to me and really cool to see. That's efficacy. In terms of correlative data, you can see the same principle here. Again, it's not meant to be a translational thing, but here's Iolos being knocked out instantly. This is the patients who got 21 days on, 7 days off. Other dosing studies are shown in the supplement of this manuscript. But you can see here very quickly, within 3 hours, boom, how quickly of that first dose of an oral pill, how quickly you've knocked down, the Iolos down to 80%, almost 100%, and so forth. And it kind of holds the line as you continue it over a 21-day period. And here, it's a little bit confusing. These are patients specifically who are pomalidomide refractory versus pomalidomide in their last line of treatment. Again, may have been some overlap here, but looking at these patients who were clearly pomalidomide exposed, and even then, forget the myeloma Icarus Aeolus effect. Focus on the right here on the T cells. You can see differences in what mezigdomide is doing to these T cells. You can see much more of these, CD8 memory cells. Activated cells are up. The proliferating cells are still present. So you can see what's happening here is a shift in terms of, an increase in number of proliferating T cells. I'm sorry, this is compared to baseline. So most patients, you're seeing an increase, not just 100%, but 203% in the number of T cells. You're seeing more activated T cells compared to before, etc. Again, not randomized studies, but it's before and after, so to speak, which is kind of cool to see. Finally, in terms of safety for this Mezi-Dex all-oral doublet, again, going back to the Pollock study with RD as the control arm, you can see here that here, at least in terms of any grade toxicities, things seem to be a little bit more manageable, or at least not worse, right? So we didn't talk about muscle spasms, and that was low with iberdomide dex, but certainly if you had told me earlier 5 to 6 prior lines of treatment, triple class refractory, I would have expected a lot of them to have fatigue, whether it's related to the study drug or just disease. Here, about the same. On the other hand, there were toxicities, just so I don't seem like a total cheerleader. Grade 4 neutropenia occurred in 54% of the dose expansion cohort. I'll talk about that more in the next section about strategies to manage neutropenia with this particular drug and how often you need to do it, but that is an issue, right? And so we'll talk about this, but the party line is that these cell mods tend to have equal, if not slightly more, hematologic toxicities because they're really isolated in the bone marrow, but not as many non-hematologic toxicities, for example, fatigue, diarrhea, constipation, myalgias, etc. So, in terms of combining these two studies together, what do I think, right? Difficult to say because these are obviously single-arm studies. These are not Mezi and Iber have not been compared in a randomized manner against each other. Mezigdomide in the previous section, you remember, seemed to hit the Aiolos and Icaros more potently. So that seems to be maybe what we're seeing here, right? Pretty good responses even in patients who, are pretty heavily pretreated. Maybe some more side effects, a little bit harder to say because a lot of this depends on the dose. Mezi Dex, I think, is very impressive as a doublet, right? All oral doublet to see that much of a response rate is very impressive. 50% response rate in BCMA exposed patients, even more impressive. And then there have been several studies. I've only shown one here. But again, even despite the infancy of these drugs, the improvement in T cell health is very clear and very apparent that you end up getting more T cells and more functional T cells as a result of these kinds of drugs. So now, with that, I'll pivot to two abstracts that were presented at the 2025 IMS, International Myeloma Society meeting. Just like before, I'll do one iberdomide study and one mezigdomide study. So this first one was a follow-up of CC220 MM001 with new cohorts I'll talk about, in particular iberdomide, daratumumab, and dexamethasone, so IBER-DD. First author, Dr. Sureda, but Dr. Sagar Loniel was the presenting author. So this is IBER-DD. So you may remember mentioning that before. IBER-DD is iberdomide, daratumumab, dexamethasone, the same regimen that was studied in relapsed myeloma in the previous section, Excalibur RRMM. Here, you're looking at it in newly diagnosed multiple myeloma. So you can see here, it's a phase 1/2 trial here. These are patients who are previously untreated. No transplant transplant is either not being planned or a transplant ineligible, obviously has a measurable disease. 25 patients got each of these, and you're looking at all the various phase 1/2 phenotypes for endpoints in terms of IBER, DARA, DEX, in terms of how it does. So again, similar to probably Maya or IFM 2017-03, probably the most appropriate comparisons because these are patients whom you think would do well with a triplet. If you want to compare it against Cepheus or IMROZ, you're more than welcome to, or as a benefit study of quadruplets in this patient population, you're more welcome to. But again, this is of a triplet, to be fair. So I think the biggest example here in my mind is lenalidomide DARA-DEX, which again would be very similar to the Maya study or to IFM 2017-03 that was recently published by Dr. Manier and colleagues, right? That was DARA-RD with the dexamethasone sparing where DEX was stopped after 2 cycles. You can see here, again, 75 patients, so a good amount of patients. Over half of them are over 75, which makes sense. These are transplant ineligible patients. But 41% of them had high risk cytogenetics by the old criteria, including gain1q, amp1q, etc. You can see here, I'm going to newly diagnosed patients, which is why this number looks so good, but it actually looks shockingly good, right? 95% response rate for IBER, DARA, DEX for this triplet regimen with oral iberdomide, including, over almost 2/3 of patients who achieved a CR. Here, I'll come back to this, right? Almost 2/3 of patients achieved MRD negativity. In all honesty, for my patients who are getting a triplet therapy, I don't really talk about MRD negativity. That's more the domain of quadruplets and CAR T and bispecifics, all the exciting thing that Mohammed alluded to earlier, right? That we always get excited about. Here, 64% MRD negativity at 10 to the -5 is actually fairly impressive. And over half of them achieved both MRD negativity and a CR. Time to first response was quite rapid. You can see one month here was the median time, and the duration of response had not yet been reached with a good amount of follow-up here. In terms of safety, hard to compare because we're looking at several dosing cohorts here. But I'll just draw your attention to grade 3 and 4 fatigue and rash and diarrhea are basically non-existent. Even any grade fatigue is pretty low, right? 24, 32%. All of a newly diagnosed patient, when you start, especially someone like this, older, frailer patient, not transplant eligible, if you were to start them on lenalidomide 25 milligrams, that was done in the Maya study, for example, they would notice. You would see the fatigue. Many of them would get rashes, some would get diarrhea, etc. Here, this does seem to be lower than what we would expect. This, I think, is a very important slide that Dr. Lonio presented last month. So, you hear that these cell mods tend to cause more neutropenia. Absolutely true. I think the key point here is that it tends to be in the first cycle. So my impressions here, a couple of things. One, obviously, as you go up, the relative dose intensity starts to lower, but overall 82% and at IBR 1 milligram, which again is probably where the drug will be rolling with in this combination with daratumumab, 91% relative dose intensity, right? So that's relative to what the patient was supposed to be taking per protocol, what they actually got. Over 90% is actually fairly solid as the median RDI across all cycles. And you can see here on the up left here, the neutropenia is much most prominent in cycles 1 and 2, and tends to dissipate over time. And infections tend to be per cycle pretty low in the 20% vicinity. What Dr. Loniel said about this was that, this is probably reflective of disease burden more so than the drug itself. In terms of what do I mean by that? If iberdomide was truly destined to cause neutropenia at every dose level all the time, forever, as long as the patient's on the drug, you would be seeing, neutropenia all grade happening at the same frequency throughout the study, or you would see a much lower relative dose intensity. If a lot of patients were being dropped from 1 to zero point 0.8 to zero point 0.6, etc. The fact that you saw a 92% dose relative dose intensity, so many patients are able to hold the line at 1 milligram as iberdomide dose, and then the neutropenia stays way low here, may reflect GCSF usage, but it may also reflect that these patients should have a lot of disease in their bone marrow. And with all the stuff happening in the bone marrow during cycle 1, that's where they get neutropenic. But after a couple cycles, as they've been debulked, median time to first response 1 month, response rate over 90%, as the myeloma starts to behave and knock out of the picture here, you're often are able to maintain that dose. So that was the new paper, the new oral number 1. The second new oral that's worth discussing would be this particular study. So this was a different cohort of the CC92480 MMO2 trial. So this was presented by Albert Oriol and colleagues are presented here. You see the authors listed here. What they did here, as I'll talk about, is pooling mezi-KD, so mezigdomide carfilzomib dexamethasone, with mezi-VD, mezigdomide bortezomib dexamethasone, looking at the synergy between a cell mod and a proteasome inhibitor. Here, again, phase 1/2 study, so it's very difficult to kind of say this is the one dosing pattern because they looked at many of them, but various MESI triplets. In this particular case, they pooled the results of these 2 cohorts shown here, or actually 3 cohorts technically, but looking at MESI VD or MESI KD. You can see here the MESI doses went from 0.3 to 1.0 in both cohorts. And then you can see that the bortezomib here is twice weekly, but then goes to once weekly. And here the carfilzomib is once weekly and then goes to every other week for maintenance in these respective cohorts. 76% of these patients are IMiD refractory, 19% triple class refractory, over half a high risk of genetics. Same idea, right? These are the patients where, in general, you are running out of options for them, trying to see what will work for them. Will this cell mod plus a PI work well? You can see here, so the answer is yes. So if you look across all cohorts here, again, what they're doing here is they're breaking things up by prior lines of treatment. They're trying to show that CELMoDs work well even in later lines in these patients who have been more heavily pretreated. And you can see that it's actually indeed the case, right? So response rate of 84% in 1 prior line, going down to 71% in 4 prior lines. So maybe a little bit of a reduction, obviously very small n. One more response would have tipped this into good territory. But across the board, no matter how you slice and dice the data, over half of patients, really over 3/4 of patients, are achieving a response with this type of triplet. You can see here that median PFS, again, same principle. So if you go from 1 prior line in blue to 4 prior lines in black, again, the patients who have 4 prior lines don't tend to do as well. That could be a function of prior treatment refractoriness. It could just be disease biology. Patients who require more lines of treatment obviously won't do as well because they have more aggressive disease clones that have been refractory to prior treatments. But across the board, even there, you were seeing some good data here. This is the PFS curve here, but you're seeing even in this particular group, right, the patients are often doing quite well here, here, and here. So you're actually seeing I actually don't know if the median PFS is actually listed. Oh, here it is. Yeah, median PFS from 9 months to 19 months for these regimens is pretty impressive. In terms of safety, unfortunately, they only showed grade 3 plus AEs here. So you can see obviously neutropenia is happening really across the board. A lot of these patients have neutropenia, but diarrhea is pretty rare. Fatigue, grade 3 plus is pretty rare. Again, I would say that, because I try to be critical as I can of these abstracts, I think here they were given 6 minutes for their presentation. They didn't have time. Obviously, for these drugs, if you're trying to compare grade 3 cytopenias and grade 3 toxicities between mezigdomide and the older IMiDs, you may not see that much of a difference. Really, the all grade toxicities is what I'm more interested in. And obviously, the publication, I'll be very interested in that. And I suspect, as before, it'll be lower, right? So to reiterate here, I suspect that if you look at all grade fatigue, all grade diarrhea. Those are the ones that for these older, frailer patients often I struggle with, right? The grade 3, I know what to do, stop the drug. But just in general, for these lower grade, will they respond? Can they maintain on drug, etc.? I suspect we will find that these non-hematologic AEs are lower with CELMoDs like mezigdomide than they are with lenalidomide or pomalidomide, etc. So finally, so we are right on time here to end at 10:20 here and leave time for questions. Mm, my unsolicited, or I guess I can say solicited, because Dr. Multi kindly invited me to be here, my thoughts on this, right? As a practicing clinical hematologist, how do I look at these data with the caveat that these are very early phase, right? If you're looking for a phase 3 trial of either of these drugs, we actually have a press release. We don't have anything more than that. So we don't have everything yet, but based on what we know so far and what we've seen in the last month at IMS and the press release that came thereafter, what do I think of these? So I think I'll break it into newly diagnosed myeloma versus relapsed refractory multiple myeloma. Let's start with newly diagnosed myeloma. These data that were presented at the IMS meeting by Sagaloniel and colleagues are very, very compelling. So again, cross-trial comparisons are bad. We tell everyone not to do them, and then we go and do them. So I'm going to do them. Here, I'm going to compare it to Maya, right? Because I think this is probably the best comparison here. A triplet regimen with a CD38 monoclonal antibody in patients who are truly transplant ineligible, including many patients aged over 75, and seeing how they do. Again, very different here. Maya had, over 100 patients in each arm. Here it's only 75. I get it. And here, obviously, the active agent is lenalidomide, or in this case, iberdomide, but the patient population is otherwise relatively similar. Response rates are relatively similar. I will openly buy that, right? If you're looking to move the needle on response rates, it's going to be hard to do because DARA-RD is a very good regimen and it's actually getting better with the IFM 2017-03 dex sparing approach. But where I think things are pretty interesting here is what's down below. So if you look at MRD negativity, different things here. Obviously, there's a lot of cross-trial comparisons in terms of how you actually define it, how you calculated it. Here, in both cases, 10 to the minus 5, for what it's worth, was used as their cutoff. So 1 out of 100,000 cells. In Maya, by NGS, they had a 24% MRD negativity rate. Here, with IBER-DD, 64% MRD negativity by next generation flow. So 2/3 of patients. Wow, that's very impressive, right? For these patients, if you believe that MRD negativity is a helpful endpoint, as I absolutely do, then that's very impressive because these patients are probably in deep remission. They will do better. They're able to hold the line for longer. Similarly, if you look at this again, there's different doses in the IBER study, but at the IBER 1 milligram dose, which is what they're typically going to go ahead with for IBER DD in general, 91% relative dose intensity. So most patients are able to maintain that dose. If you compare that to lenalidomide at 25 milligrams in Maya, only 76%. So a lot more patients were requiring dose reductions. And for all grade fatigue, again, difficult to compare, but certainly at least it's not worse with this newer drug. Appears to be better, if anything, 31% for IBER versus 40% for lenalidomide. So that's newly diagnosed myeloma. Again, making a point here of MRD negativity and then the active drug RDI of the IMiD being much better. Moving to relapse refractory multiple myeloma, again, we've already seen an MRD negativity benefit. By seeing, I've heard about it on the internet. I'm very much looking forward to seeing these data. I'm sure they'll be presented at some conference quite soon. The reason that this particular study has MRD negativity as a primary endpoint, of course, is that in both the United States and in Europe, regulatory agencies are willing to consider MRD advantage to be used towards drug approval. And so MRD negativity was added as a co-primary endpoint. We obviously need the PFS data. We don't have that. I don't know the magnitude of the MRD benefit, but I know that there is apparently an MRD benefit with IBER-DD, with iberdomide as a partner drug, as opposed to DARA-VD with bortezomib as a partner drug. Some caveats here. Again, many of us in the United States and probably in Europe and across the world as well would be able to use a carfilzomib-based triplet. That was not the control arm in this particular study. They used Dara-VD based on the older Castor study, and maybe Dara-KD is a little bit of a stronger regimen, but still, MRD negativity is pretty interesting. Many studies are looking at cell mods in all sorts of combinations. I could spend half an hour talking about these trials. Many of you may have patients on these trials. What I think is interesting is some of these trials are specifically focused on the T cell engager aspect very, very openly. So, for example, this is just one example. This is a phase 2 randomized trial in the United States using ide-cel, so CAR T cell therapy, and among patients who achieve at least some level of response, they're either adding iberdomide versus observation to see if iberdomide, probably at a lower dose, we'll see, in the maintenance setting can help hold the line and keep people in remission for longer. So that's newly diagnosed and relapsed refractory myeloma, particularly with an eye towards efficacy. Moving to cell mod versus IMiDs for tolerability. I think this is a take-home message that I think many of you will come away with if you haven't already heard. It is somewhat of a dogma, right? Because we don't have a randomized trial here. So the dogma, the traditional teaching is that cell mods will have comparable, if not slightly worse, hematologic adverse events, most notably neutropenia, compared to the older IMiDs. But the non-hematologic AEs, so the fatigue, the rashes, the constipation, the diarrhea, all of that should be lower with these particular drugs, given that they kind of really dive in and focus on the myeloma and less of this off-target stuff. Again, you could argue we don't know that. We don't have a randomized trial. There is a randomized trial coming. So just so I put it out there, there is a separate from Excalibur RRMM. There was an Excalibur maintenance trial that's actually looking at iberdomide versus lenalidomide, as noticed here for the maintenance treatment. I like this because just like the other trial, they have this course correction mechanism. So even if Iber 1.0 milligrams is the dose in a different setting, let's study it here in the setting of Iber maintenance. And if you see that a different dose level ends up being better, you take that in the phase 3 study and use it for the second half of the phase 3 study with lots of patients here. I don't know, over 500 in each arm. So we will certainly see, and that will give us a head-to-head comparison of toxicities between these agents. I think iberdomide will win. Finally, now in terms of which drugs are better, right? So CELMoDs versus IMiDs. We're not going to be able to answer that question today, but as I promised, some sort of a meme or cultural reference in my talks here. This question, I think, to the 1946 Broadway musical, for any of you who are have heard of this, called "Annie, Get Your Gun," has been in many advertisements since then, where he's saying they're competing, and she's saying, "Anything you can do, I can do better." Little clip of her doing that and walking off the stage here. And I think that's actually fairly accurate for IMiD versus cell mods. Anything an IMiD can do in terms of myeloma or T cells, a cell mod can do better. Just to make that very clear here, right? So if you were to look back at the study that I presented from IMS 2025, that Sagalonio presented, looking at IBER-DD in newly diagnosed myeloma, these patients compared to Dara-RD seem to achieve much higher rates of MRD negativity and probably will hold the line for longer as a result. In the relapse setting, we're probably seeing the same thing as well. Better tolerability, which I think is really important. Again, I'm always on the soapbox that I think for IMiDs and CELMoDs in particular, these all grade AEs can be very concerning for patients, right? Especially if someone's on this drug for years, grade 1 fatigue can build up. And if it's lower with these drugs, excellent. And again, despite the relative infancy, there is plenty of data already, including all the correlatives from all these studies, showing that these drugs are able to make T cells work harder, faster, better, stronger, independently of their myeloma activity, which is wonderful. And so finally, to wrap things up here, this is a slide that I promised I would talk about. It's a little bit controversial, right? Even if you were to look on social media, there are people who are out there saying, well, a Selma is just an IMiD. It's just a newer generation IMiD. It's really weird. It's like corporate branding to call it different, et cetera, et cetera. I do not pretend to be a corporate branding expert. I have nothing to say on that front. But this is where I would draw the line, right? So this is my heuristic, my decision-making process for delineating classes. If I was looking at a study down the line of something different, let's say of CAR T therapy or bispecific antibodies or something different, would I want to know what percent of patients had gotten all of these drugs pooled together, or would I want to know what percent of patients had gotten IMiDs or what I had gotten the cell mods? If we were to quote Shakespeare, right, this would be this question, right? What's in a name? That which we call a rose by any other name would smell just as sweet, right? Is that what he would say? That, oh, who cares? Cell mod, IMiD, they're all the same thing? Or would he be a little bit more provocative and say, oh my God, table one, why didn't you say what percent of patients are CELMoD refractory? Because that's what I really care about in the year 2029, because CELMoDs are the standard of care, and patients who are CELMoD refractory have poorer outcomes and don't group CELMoDs and IMiDs together. Long story, but I would say that second Shakespeare is probably where I would draw the line, and probably many of you as well, right? From what you've seen here, showing that these drugs just behave so differently in terms of MRD negativity, in terms of efficacy, in terms of safety, in terms of mechanistically how they work. In the future, I want to know what percent of patients were CELMoD exposed or went on to a CELMoD as post-progression therapy. I don't, in my head, treat them the same way as IMiDs. So if I don't treat them in the same way as IMiDs in my head, they're a different class. And if again, if you feel the same way as I do, then I think CELMoDs really should be viewed as a different class of drug. So that in mind, I will stop kind of right on time here, 45 minutes. This is the slide I always end with, our goal for myeloma, to have people get problems that have nothing to do with their multiple myeloma. Thank you all for this invitation, particularly Mohammed, and I'm happy to take questions. Thank you again.
Thank you very much, Raul. This was really fascinating, and I think you managed to share your excitement and enthusiasm with the audience. We have plenty of questions and a lot of comments actually about people saying, oh, they are convinced that's going to be the new class of drugs in multiple myeloma. So we won't be able to take all the questions, but I'll give you a few questions
Hmm.
which I believe are important for practical, for the routine practice. Do you think one can use these cell modes, whether iberdomide, mezigdomide, to salvage patient after failure of bispecifics or CAR T cells?
Great question. So I think the short answer is yes, right? If you look at the IberDex and MESIDEX papers, probably about a 40 to 50% response rate for BCMA refractory patients. Most of the patients had received a T cell engager or CAR T. The devil's, of course, in the details, right? And Mohammed, I love your thoughts on this as well, right? So the question is if someone, relapses 3 years after a BCMA CAR T versus while they're on a T cell engager actively, can you salvage the response? I think it's two different questions. I think the question is probably talking about that latter scenario. So let's say someone's on a bispecific antibody and it stopped working in front of you. Will these drugs work to re-energize the T cells and have an anti-myeloma property? I think the answer is actually yes. Obviously, we need more data here. Why am I so optimistic about this working, at least for some patients? One, again, the data speak for themselves, that there is a response rate in the setting here. The other, though, I think if you look at the data for talquetamab plus pomalidomide, just as an example, right? So that study, TRIM2 has a cohort like this. There's a Monumental cohort like this, where what we actually do, logistically speaking, is you give talquetamab, which is a GPRC5 related bispecific first, for a month, and then you add the pomalidomide during cycle two. The reason they didn't put them together is to kind of avoid stacking side effects here. I truly have had patients where the tau by itself kind of led to a minimal response at the cycle 2 day one endpoint. You had the pomalidomide and boom, now slow, you see a steady, slow decline thereafter. That may be the myeloma activity that two of those patients were actually both palm refractory years earlier. So I actually think it was a T cell activity. And again, if anything, an IMiD can do, a cell mod can do harder, faster, better, stronger. I think the same principle would apply here. Mohammed, anything you would add?
I love this analogy, and I'm convinced, obviously, at the end of the day, as usual, in the end stage, we use them as single agent, but
Hmm.
probably will move to combinations. And of course, I'm very excited about the synergy between bispecifics and these cell modes. And there is a paper pre-published in Blood last week, I think, for instance, about the importance and the probably in vitro and in animal models, the role of the synergy between
I saw.
cell
Mhm.
modes, iberdomide, and actually elranatamab. We have also another important question because I don't think you alluded to this. One of the key concerns with the IMiDs, especially lenalidomide, and that was around the year 2015, was the risk of secondary cancers. Do we
Mhm.
have any signal today based on what we have? Obviously, we don't have thousands and thousands of patients, but what can you say about this?
Yeah, so it's a great question. So I think it's difficult to say for sure. I would say the short answer is ask us again in 2030 and we'll have some more information then. However, I will say that there were some nice data from Adam Sperling's group of paper in Blood a couple years ago, comparing lenalidomide to pomalidomide ex vivo in terms of the risk of secondary MDS or AML, secondary myeloid cancers. And they actually found that lenalidomide in particular has some dirty baggage in terms of messing with TP53 and leading to TP53 mutated myeloid clones growing a bit more rapidly. At least in that model, pomalidomide did not have that side effect. I would like to probably believe that because POM, is kind of more on the spectrum of closed Icaros, so just the way that it works, probably whatever POM is doing, Mezi and IBRA are doing it even more so than that. So I actually think that the second primary malignancies risk probably will not be as relevant here. Again, if someone lives longer with mezigdomide and they live long enough to get a complication of the transplant or something different, that's a different matter. But truly, all of us have had patients who definitely got a lenalidomide associated, ALL later in life, which sucks. Hopefully, there'll be less here. I didn't talk about this at all, actually. I think the blood clot risk, just going through IMiDs as a class and CELMoDs as a class, forget the fatigue, forget the diarrhea, just big picture stuff. So the SPM risk, I think, hopefully will not pan out. That's my goal. Mohammed, I'd love to hear your thoughts on this in a second. The VTE, venous thromboembolism risk, probably my guess is that that probably is still real. Hard to say. I think at least the trials do include VTE prophylaxis, right? Better to be right than wrong about that. The teratogenicity part, I'm very curious as what's going to happen with this, with a different class, because at least in the United States, this REMS requirement that restrict the risk, I don't mean R, or something, a risk evaluation mitigation strategy is horrible, right? Our patients hate it. They're being asked to do pregnancy tests all the time. It's really, I think, actually sexist in a lot of ways. Only the women are being asked to do it, not the men, and it's problematic. Hopefully, the CELMoDs will get around that. At least as of now, for CELMoDs on trials, they are having the same pregnancy restrictions just in case, and this kind of overbearingly, attitude around not getting pregnant, again, because of the historical thalidomide teratogenicity risk, which I understand, but who knows what'll happen with it. I don't know, Mohammed, where do you see the future
Well,
play out for
I
these?
think time will tell, and
Yeah,
I'm relatively cautious. So obviously, we need to follow these REMs and be
correct.
cautious in the beginning. And time will tell us once we have treated a lot of patients.
I completely agree.
One other question, and again, I don't think we have data, but just in case I missed it in your talk, because historically we had an issue with lenalidomide used frontline in terms of stem cell mobilization. And there was a recommendation in the years, I remember a blood paper in 2009 about the need to mobilize the cells quite early after 2 or 3 cycles if you're using lenalidomide. Any data with these cell modes?
Yeah, I would love to, if Moment, let me know if you know. I actually don't think so yet because that frontline study that I alluded to was in transplant ineligible patients. I think again, a lot of the devil's in the details of how long are patients on treatment for, what else are they getting alongside of this. I also think that our toolbox to mobilize patients is, as you know, is expanded dramatically in the last decade. We're not just doing cyclophosphamide mobilization, just like plerixafor is available as an option. Um, so I think it's a little bit hard to say. I think if you view neutropenia as a four-man surrogate of what the bone marrow is capable of. Because oftentimes I feel like if my patients who've been on Len for a while and keep getting GCSF, like filgrastim, they're beaten up. Those are the patients who often have a rougher ride with stem cell mobilization. Again, it seems to be after cycle 2 or 3 with iberdomide that things seem to be a bit more manageable. But again, we need more time to tell. And certainly for the studies of this, I would say if someone's on this drug, try to at least collect their stem cells early, even if you don't move to transplant, just in case. I don't know, Mohammed, would you add anything to that?
No, but I think today, whatever the risk of poor mobilization, thanks to plerixafor, we are able to get a single graft to everybody. And of course, we are all debating the role of transplant these
Agreed.
days, but obviously it's an important concern that we need to keep in mind. I'll take one last question from Dr. Jim O'Mell, who is a
Oh.
very loyal
Mhm.
participant to the ICH activities. And Jim is asking about whether you have any data or a case report or whatever about efficacy in the CNS, because obviously we know that this is really very hard to treat. So in other words, penetration of cell modes in the CNS, is this something we have already?
I think, Jim, you got me. Yeah, I don't know of any data.
I
I
never
think
heard of
I
about
know.
this, but
The hard part is again because the clinical trial is all excluded. So at least in the United States would have to be in a compassionate use program. I think the only caveat to the caveat I will say, because this may be a scenario where maybe pomalidomide has the edge. So lenalidomide is not thought to cross the blood-brain barrier. Pomalidomide is, for example. I will say that T cells can go wherever they want, right? And so, to the extent that I have seen patients with CNS myeloma respond to a bispecific antibody, it may be that if you combine that bispecific antibody with mezigdomide, you may actually end up seeing a CNS response, even if Mezi itself cannot cross the blood-brain barrier, but the T cells that are now energized and activated can. So this will be a case where I think it would be very nice to explore mezigdomide and iberdomide in synergy with other agents to see, because again, the T cell thing here is not a hand wavy. It's a very real phenomena with these drugs in terms of making T cells work better and more durably. And whether that can help make CNS myeloma more treatable, I think is an unanswered question.
wonderful. This is very exciting, Rahul. Thank you so much. As we close this session, one message stands out clearly. The emergence of cell modes represent a new chapter in the treatment of multiple myeloma. The classical IMiDs, lenalidomide, pomalidomide, already transformed our field, reshaping the natural history of the disease and redefining long-term disease control. But the cell modes are taking this story further. They are not simply next generation IMiDs. I hope Dr. Banerjee convinced you about this. They are a new class with enhanced potency, broader cerebral engagement, and the ability to overcome resistance that limits our current agent. And of course, in an era dominated by immune therapies, CAR T cells, bispecific, trispecific, and all these other immune engaging approaches, it is essential, in my opinion, to remember the practical and strategic value of cell modes. They are oral drugs, easy to use, accessible, and highly combinable, and they can act as powerful partners synergizing with immunotherapies to deepen and prolong responses while maintaining treatment flexibility across the continuum of care. On behalf of the International Academy for Clinical Hematology, I'd like to thank our distinguished speaker, Dr. Banerjee, but also all participants for this insightful discussion. The journey of multiple myeloma therapy continues to evolve, and cell modes will undoubtedly play a central role in shaping its next phase. This is the International Academy for Clinical Hematology around the globe and across the hematology field. Wherever you are, please stay safe and take care.
Thank you, Mohammed.